well. Tanya told you all about my official experience. I have also used drugs for my entire life. One of the things that my parents love to tell me about is that when I was like 2, I found an open bottle of cough syrup and just downed it. And apparently I had a super good time with it, and I've had a super good time with drugs since then. I'm one of the lucky folks who's also who's also the majority of folks that use drugs and don't find it to be problematic. So I bring experience from lots of different areas. My pronouns are she, her, hers, or they, them, theirs. And I've found and been told by folks with trans experience that rather than asking people what their pronouns are, which can feel kind of like, how do you decide who to ask if you're not asking every single person? It can feel kind of like calling them out or suggesting that maybe they don't pass or something. So I find that as a provider, just as a part of my introduction, telling people what my pronouns are can open up that conversation if people want to talk about it, but you end up not necessarily suggesting that someone is obviously trans. As a part of all of my presentations, I try to acknowledge that the land that we're standing on does not belong to us. This land rightfully belongs to the Piscataway people, and I am sure I'm not pronouncing that right. I hope there's somebody in the room that can help me correct that. So on this slide, we have a photo of the local tribal chairwoman, whose name is Natalie Proctor. And in order to ensure that we're not just saying, oh, we pay respect to elders past, present, and emerging, I plan to visit the museum tomorrow morning, and I invite other folks who are in town, or if you live here, to give some time, treasure, or attention to the local indigenous nations. I also want to point out Living the American Indian Experience is a program that goes out to schools and other locations and teaches people about Native American arts and crafts and lifestyle and culture. And that top picture is them, looks like at an elementary school, working on some craft projects. Their mission is to be a resource of empowerment, preservation, and social change for Indigenous communities in the Chesapeake region. So I invite us all to think more about our Indigenous populations, and especially when it comes to reproductive justice and reproductive health. We all are very aware that people of color in general have worse outcomes, receive worse care, and the healthcare disparities are vast, and they're preventable. They're not intrinsic to not being a white person. And we see those disparities even greater for Indigenous people than for other folks of color. Just because the numbers are somewhat small in our country, I don't want us to forget about those folks. Indigenous women are 6 times more likely than white women to be arrested for a drug offense. And that compares to Hispanic women and Black women being twice as likely as white women to be arrested for a drug offense. So the disparities are massive for this population.
The next day, I found out that the Piscataway Museum had been closed, so instead my partner and I visited the Reginald F. Lewis Museum of Maryland African American History and Culture, which I highly recommend. Later that week, I was honored to be able to speak with Natalie Proctor on the phone, and that conversation was very difficult for me, but necessary. Natalie told me that in her youth, she had been trying to raise awareness of her people and their needs and existence, really, but she quit accepting invitations to events after going to event after event and never seeing any kind of change. The museum itself was only open for a few years before it had to close down, so now Natalie and other members of the Piscataway Nation participate in the Living the American Indian Experience program. They go to schools and other locations, like I said in my presentation. They also have a yearly invitation to present their program at Mount Vernon, which was George Washington's slave plantation. She said even though they feel really welcome and really grateful to be able to present their history, they've had to censor parts of it due to non-Indigenous people's discomfort with the ugly parts of our history. If they're not wearing feathers and leather fringe, they are invisible. And people don't want to see them moving into the future, but also paradoxically don't want to acknowledge their past. Natalie hopes to bring their story of their culture and their history to other colonized and war-torn people. Please consider making a donation at the piscatawaindians@gmail.com. I realized I forgot to mention it in my actual presentation, but the photo there is a picture of the cover of a book called Where's the Mother by Trevor McDonald, which is about his experience as a trans man birthing and chest feeding his two children. I highly recommend it. It really gives you an intimate idea of what that experience is like and helps me personally be a better caregiver to my patients.
I'm so excited that everybody's talking about language, and I've already gotten some tips and made some notes about ways that I intend to change my language around these topics. Here's my 2 cents. I like the term neonatal opioid withdrawal rather than neonatal abstinence syndrome. There's a few reasons for that. I forget if she said it in my introduction. I work primarily in newborn intensive care and postpartum. And one time years ago, there was this family. Mom said, I only use cocaine. She only tested positive for cocaine. Baby only tested positive for cocaine. We gave that baby morphine for 2 weeks, which is just clinically, that's not what you should do. And I think part of why that happened was because of the term neonatal abstinence syndrome. It's not precise, and it doesn't really call it what it is. So when we're talking about babies who have been exposed to opioids in utero, I like to use neonatal opioid withdrawal because it specifies exactly and precisely what we're talking about. There's no evidence-based set of signs that newborns exhibit for any other class of drugs other than opioids, so I want to call it what it is. Also, rather than using terms like addiction or addict, or even substance abuse or misuse, I prefer using person with substance use disorder or person who uses drugs. If it is problematic as defined by the patient, then I would use the first one, and if it's not problematic, then I would use the second one. For babies, babies cannot be born cannot be born addicted. They are born with a physiological dependence. Addiction is basically a slang term. It doesn't really mean anything medically. Way back in the day, it used to mean a set of behaviors such as neglecting responsibilities and drug seeking. And if you think about a newborn baby, they can't do any of those things. So it doesn't work for that purpose. The DSM-5 and also the DSM-4 before it use the term substance use disorder, so that's what I like to use also. Not necessarily related to drug use, but just related to our times and being respectful of our clients and our patients. I like to make sure that I talk about women and other people who can become pregnant when I'm talking about this population. So that includes LGBTQ families, non-binary families, poly families. Knowing the term cisgender, it can be really helpful. And for any of those of you that haven't heard that term before, cisgender means someone who, when they were born, the doctor looked between their legs and said, that's a girl. And when they grow up, they feel, yep, I'm a girl. That's what cisgender means, just in case you haven't heard that term before. Some terms that can that can be helpful in caring for transgender and non-binary people are chest feeding, gestational parent, rather than mother all the time, pregnant person. There's tons and tons of ways to talk about this, and at first it feels clunky and difficult, but after a while it just rolls right off the tongue. Also, I want to say, I don't think that there's a right way to do any of this. It's evolving, and we're all learning together, and I'm probably going to mess up during this presentation, and that's okay. We just need to make sure that we're trying. All right. Opioid use in pregnancy. It's very similar to opioid use not in pregnancy. We can predictably see with pregnant people, if they're regularly using opioids, you're going to get tolerance, which means that the person requires a higher dose to achieve the same effect. And we're going to get dependence, which means negative symptoms occur when that use is discontinued. Some specific things about pregnancy that I think as providers, we only see the person for a snapshot, for a small portion of their life. And a lot of times my coworkers don't seem to realize that this has been a lifelong issue for this person. Sometimes it seems like folks assume that, oh, she got pregnant and then she was like, I think I'm going to start up a heroin habit. That's not how it happens. These are people who are struggling with opioid use disorder and then find themselves pregnant. And so it's really important to keep that in mind. Nobody sets out to have a problem. Nobody sets out to do something that is going to cause effects in their baby. And then the other thing that I want to point out is that pregnant people generally decrease their use. When we do studies, not just for opioids, but for all substances, we find that the first trimester we have higher rates of use. And part of that is because for about half of the first trimester, most of us don't know that we're pregnant. And then there's a linear decrease from first trimester to third trimester with all substances. And so it's really important to acknowledge that even if this person, as they're presenting to you in labor or wherever you interact with your folks, even if they seem to have a pretty severe issue, they have probably already been taking steps to improve their health and improve their chances of having a healthy pregnancy outcome. And it's really important to acknowledge that, because oftentimes we see people and they're like, you need to do this, this, and this. And we don't ask them, hey, what has worked for you in the past? What steps are you taking? And to acknowledge that and to celebrate that is really, really important in developing a rapport with your clients. So there's a lot of overlap in the boxes: pregnancy concerns amplified by opioid use, opioid concerns amplified by pregnancy. We know that pregnancy is a risk factor for intimate partner violence and other forms of violence, and we also know that obtaining and using opioids can also expose women to vulnerability to violence. Just to get real for a second, constipation and hemorrhoids. That's something that happens to most pregnant people, usually later on in pregnancy, and particularly if they have vaginal delivery. Just about everybody will end up with some hemorrhoids. And we know that opioid use causes constipation, tends to dehydrate people, and also causes hemorrhoids. So that's something that you can talk about with your folks. It's really easy to do things to mitigate that. So you can advise people avoid bananas and white bread, instead eat whole grains and figs. Drinking lots of water, walking a little bit each day, all of these things can mitigate some of those issues. In pregnancy, there are metabolic changes that throughout the pregnancy either increase or decrease your metabolic rate. So that means if you're using the same dose, it's going to act differently depending on where you're at in your pregnancy. And this translates to our patients that are using methadone or buprenorphine needing to adjust their dose perhaps a few times throughout their pregnancy and in the immediate period after delivery, the postpartum period. Sleep can be a really tough issue, especially later in pregnancy. And with opioid use, you can kind of get interrupted sleep patterns and circadian rhythms. Nutrition is something that's really tough for all pregnant people. Everybody should obviously be taking prenatal vitamins. I hope that there are some programs that give those out around here. And it can also be an issue with opioid use because of that slowed down gastric motility that causes that constipation. People may not feel hungry, especially if there are scarce resources. People may have to choose between drugs, rent, and food, or and they might not be able to have all three. They might only be able to have one. So that's really important. Something I put on both boxes here is public scrutiny, because the public in general feels like they're allowed to have an opinion and a judgment about pregnant people and about people who use drugs. And both of these items can just make us more visible and more vulnerable and make it a lot more difficult to access services, especially because we had a pregnant person come to the syringe exchange, and the other people in line were kind of harassing her and telling her, you're a bad mom, you shouldn't be here, you shouldn't be using drugs. And so it's really pervasive, and it oftentimes comes from people that you wouldn't expect. Opioid concerns amplified by pregnancy, overdose and withdrawal. That comes with that changed metabolic rate throughout pregnancy. At sometimes, your methadone or buprenorphine patients may be experiencing withdrawal on a dose that kept them comfortable before. You can also see oversedation or even overdosing requiring naloxone just because of those changed metabolic rates. Infections are an extra concern for folks that are pregnant because a lot of the same infections that can be passed through needle sharing can also affect the pregnancy and the baby and the outcome. Exposure to individual and structural violence, especially for women who use drugs, this is really huge. What I was talking about earlier, acquiring and using substances exposes us to a lot of unsafe situations. And I forget who was talking about it before, learning how to, I think it was Emma, learning how to inject yourself is really, really important for this population. Because especially in pregnancy, partners may say, well, it's fine for me to use, but you can't use anymore because you're carrying my child. And part of that is education, because the safest thing is to keep a steady, even dose and not quit or use abruptly. But it's also just a human rights issue. Nobody is allowed to tell another person what they can or cannot put in their body, or should be, I suppose. And then isolation. We've talked a little bit about that today. Substance use that is problematic is really isolating. It's this huge part of your life that you feel like you're not allowed to tell anybody about, especially the people who care about you most, like parents and family members. And that is just amplified in pregnancy because those same folks that you couldn't tell about it before, now that you're pregnant, you doubly cannot tell them about it. So, neonatal opioid withdrawal. It's really unpredictable. We don't really know why. We have found that it's not dose dependent. So somebody that's on 30 milligrams of methadone might have a baby that has more symptoms than somebody that's on 60 milligrams of methadone, and we don't know why. Not everybody that is on some sort of opioid medication has a baby with symptoms that require treatment, and we don't know why. I suspect that it has to do with the quality of prenatal care, the evenness of the dose throughout pregnancy, and other health factors. For example, for all babies, not just babies with substance exposure, girls do better than boys for just about every health condition. We're just physiologically stronger than you guys. But so there's factors like that that can affect the outcome and the signs. So newborn opioid withdrawal is signs, not symptoms. You'll notice I talk a lot about language. Symptoms are something that is reported to the nurse or other healthcare provider by the patient. So babies can't have that. So with babies, we just have to look at them and how they're acting, and that will tell us what they're feeling. So the signs of newborn opioid withdrawal, there's a lot of them, and I'll talk about that in a second, but the main ones are irritability. So that means normal baby stuff is just going to be kind of turned up a couple notches. So like you unwrap a baby to change its diaper, it's going to cry, any baby. If you unwrap a baby with opioid exposure who's showing signs, they're going to cry longer, they're going to take a little longer to calm down. Poor feeding. Part of this is stomach upset and part of this is organization. If anybody has ever kicked in this room, you know that stomach upset is a big part of that. And the other part for babies is that when you're born, you have to learn how to suck and swallow and breathe all in a coordinated rhythm so that you don't choke on your food, and that's a brand new skill. So it's a difficult thing to learn for all babies, but particularly if you're feeling uncomfortable and you have to breathe faster than normal, so that can be an issue for babies. They also tend to have a little bit more regurgitation. So again, all babies spit up, these babies are going to spit up a little bit more. Respiratory distress. This is part of just whenever anybody's in pain, our heart rate goes up, our oxygen consumption goes up, our calorie consumption goes up. And with that, we have increased heart rate and increased breathing rate. And if you need more oxygen, you're going to be breathing faster. And if you're not able to get enough oxygen, then we might have to give babies extra oxygen through like a nasal tube or perhaps a CPAP machine or something like that. And that's more rare to need to do that, but we do pretty generally see higher breathing rates for these babies. And I got ahead of myself. That's that increased metabolism. So there's a whole bunch of treatment models and different ways that we deal with this in hospitals and in birth centers. The Finnegan is the most common. It's probably the one everyone's heard of. It's got, I think, like 31 different things that you assess and assign points to. I'm not a huge fan of it. Loretta Finnegan is a pillar and a genius, and I'm so glad that she invented this scale for over 40 years ago, but it needs to move along with the times. A lot of these things are really subjective. If the nurse wants the baby to either start on medication or up their dose or decrease their dose, she can, or he can pretty much get whatever score they want and justify it. There's things on there like excessive crying. What's that? Is that a hungry baby? Is that a baby with a wet diaper? There's high-pitched cry, which again is really subjective and means different things to different people. We also score things that every single baby does. For example, they get a point for sneezing. They get a point for yawning. There's pretty much every baby, when they're startled, they'll do a Moro reflex, which looks like this. And jitters, which is scored on the Finnegan scale, looks like this. So it's really, really similar and very easy to just give whatever score you want. And that's my soapbox about the Finnegan. Lip sits is a modified Finnegan, basically, that they use at lower level nurseries. It's a little bit easier. I think it only has 13 things, but it's still really subjective and it's based on the same idea. My favorite new thing that's happening and coming out right now is the Eat, Sleep, Console method. And this throws away all that subjective stuff and just asks you 3 questions. Can your baby eat? Can your baby sleep at least an hour? Is your baby consolable within 10 minutes? If you can have a good answer to all 3 of those questions, then your baby does not need medication. And I really like this method because there's tons and tons of studies, but one that they presented at a conference I put on last year, they decreased their treatment days from like 30 some odd down to 6, and most of their babies just had a couple of morphine doses. And what we normally do with Finnegan is once you reach a certain threshold of high scores that requires dosing, you just dose them around the clock every 3 to 4 hours, like for a long time, until you establish a dose that keeps them calm and comfortable, which usually takes a couple days. Then you stay there for a couple days, and then you start trying to decrease, which takes forever. So the cool thing with Eat, Sleep, Console is that you only dose when they need it. If they can't eat, you can also do alternate methods of feeding them. We can put a tube through the nose and into the stomach that can help get them those extra calories. And then for sleep and consolation, if they're not sleeping, if you can't get them to calm down after 10 minutes, then you give them a dose of morphine. But you don't just start dosing and then keep going. So it really, really decreases the length of stay. It also partners with the families. Because if you think about it, if you're uncomfortable and your tummy hurts and your butt might hurt because you're having loose stools and diarrhea, the last thing that we should be doing with these babies is taking them away from their families and putting them in a noisy NICU with beeping monitors and flashing lights and other babies crying. So the way that we've dealt with this historically, we're making it worse, a lot worse. And so I really love the Eat, Sleep, Console method because it partners with parents. It asks the parents to help in assessing the baby's state and let the providers know, do you think your baby needs a dose right now? Or do you want to try consoling a little longer? So that's huge. Partnering with the parents. So this is another thing I think I left off my slide. I like the term opioid agonist treatment. I've heard a few terms throughout the day that I'm like, oh, I might have to think about that. The reason I like this one is because I don't like the other ones, A. Medication-assisted treatment is a silly term. We use medications for all kinds of conditions, and we don't call it medication-assisted treatment for anything but this, because we have this idea that methadone and buprenorphine are bad medications. And we're like, well, we're not just doing that, we're doing all these other things too. But we do that with every health condition, with high blood pressure, with diabetes, with cancer. There's always going to be lifestyle changes that are involved in treating any health condition. And singling out substance use disorder just adds to the stigma. I don't like maintenance or replacement. Those words suggest that you're, not to people in this room, but the people that we argue with out in our jobs. It suggests that you're just replacing one addiction with another. And so I like opioid agonist treatment. Agonist is a term in pharmacology that means something that turns on a receptor in our brain. Antagonist is something that turns off a receptor in our brain, and blocker is something that plugs it and doesn't do anything. So opioid agonists are your methadone, buprenorphine, and all of the other ones, heroin and morphine and all that. Those are all opioid agonists. And I like this term because it is precise. This is, and has been for decades, best practice for pregnant people. This is not controversial, this is well established. Everyone who has an opinion on the matter has said so. The American College of Obstetricians and Gynecologists, the American Academy of Pediatrics, the Association of Women's Health, Obstetric and Neonatal Nurses, the American Medical Association, what's ASAM again? Anyway, all the addiction medicine people too. We all agree, yet we're not doing it. And this is something that I see a lot in the area of perinatal substance use. We have all this evidence saying what we should do, but we don't do it, because we also like to hold on to our idea that these are bad people and they should be punished. I'm a big fan, like Emma mentioned earlier, of heroin treatment. Heroin, or diacetylmorphine, also known as diamorphine, is just another opioid. It's not the boogeyman that we've all been taught to believe that it is. 10 minutes after injection, heroin is transformed into morphine in our bodies. If you go to the hospital and get surgery or have a baby, you're probably going to get some form of morphine. And so it's nothing fancy, so we just need to get over that. The World Health Organization recommends heroin as effective and appropriate treatment during childbirth and labor. And it's just in this country that we seem to have this idea that it's the boogeyman. I put up a couple studies up there. Salome and Naomi were studies in Canada where they provided people with 2 to 3 injections of pharmaceutical heroin each day. And this was for folks for whom other treatment methods had failed. And that's another intentional language thing that I do. The patient doesn't fail, the treatment fails. If you go for chemotherapy and your cancer doesn't go away, are you a failure, or did that drug fail to help you? So that's a really important distinction. Naltrexone is getting a lot of attention lately, and people like it because there's no, naltrexone is a blocker. So it's like naloxone, but it's longer acting. And I suspect that people like it and are trying to push it because there's no chance that it could be fun. And we don't want our patients to feel good or have fun, ever. That's very naughty. We don't really totally know why naltrexone works, we don't necessarily know that it works. It seems to work for some people. And the thought is that it doesn't necessarily block a specific receptor, it blocks pleasure in general. So it can kind of blunt the feeling of pleasure that people get when they use substances. And I say this should still be an option because I believe that every patient has the right to make their own treatment decisions for what they want to do. But I don't like how we're pushing this on folks, particularly incarcerated populations and people with less power, people on the margins, because it's suggesting that, we don't care what you do, just as long as it's not fun. And I don't like that. I like fun. So this seems kind of obvious, but I just love the way it's phrased. Threats of arrest or criminalization do not increase a parent's ability to stop drug dependency. And I would add to that, threats of having your kids taken away, or threats of being, having surprise visits from CPS you guys call it something else out here, child protection at all hours of the day or night. That isn't going to help anybody do better. Surveillance and punishment are not health care. And it seems silly that we have to say that, but we do, and so there it is. Detox. This kind of goes along with the naltrexone conversation. In order to be put on naltrexone or Vivitrol, you must first detox. And we're starting to get a little better information, but what we know is that detox puts a lot of stress on the body, and whatever kind of stress the pregnant person is feeling is also happening inside the uterus. So that can cause fetal distress. We have some case studies, not super strong evidence, but when you're talking about losing a pregnancy or fetal demise or miscarriage, even those case studies we should pay really strong attention to, because it's not a minor, subtle thing. Miscarriage is a big deal. So if clients are highly motivated and ask for this, they should be offered that option. It should be a really thorough discussion of the risks and benefits. The other risks of detox are overdose and starting to use again. And for some folks, just getting stability throughout their pregnancy and dealing with one thing at a time might be an easier and better option. So, methadone and buprenorphine. A lot of folks that I work with say, well, she's never going to get off of it. Who cares? The point is not to get off of opioids. The point is to not die. That's the point. And methadone and buprenorphine are both really strong binders to those receptors in our brains. So a lot of times if folks use other drugs on top of it, there won't be as much of a rush effect. So it really can help decrease cravings. We know that people who are on methadone and buprenorphine, not all of them, but a good proportion of them continue to use illicit drugs. And that doesn't mean that they should be taken off their methadone and buprenorphine. They tend to continue to use, but they also continue to use dramatically less and to decrease their use as time goes on. The other thing is in pregnancy and labor, if you are on methadone, that is not pain control. And I see this in my work a lot. People are always saying, oh, well, you don't need other medications because you're on all that methadone. No, that's what they need to feel normal. You need to give people more medication on top of that for labor, especially if they have a C-section. Drug seeking is a term that I hate because every time it's applied to somebody, they're seeking drugs that are usually appropriate. I've had countless people going to get abscesses lanced, which, if you know, that's an incredibly painful procedure, and they're told they can't have pain medication because they're drug seeking. Yeah, they're seeking appropriate drugs for their appropriate health condition. So that's a really, really important thing to remember. Another thing that is a benefit of opioid agonist treatment is decreased infection risk. So even if you're still injecting, if you're injecting less, that's less chances of getting one of those infections that can affect your pregnancy and your baby. Improved stability in your life. Getting money to buy drugs and finding drugs and buying drugs and using drugs takes up a lot of time for a lot of folks. And so just being able to have that stability and not have to worry about that can be transformative for a lot of these lives. Buprenorphine is probably better than methadone for pregnancy, for neonatal outcomes. We have a few studies in the last 10 years or so showing slightly decreased, but still statistically significant length of stay in the hospital, length of treatment for babies that were exposed to buprenorphine rather than methadone. Now, if somebody's not on any kind of treatment and they become pregnant, we're going to start them on methadone rather than buprenorphine, because methadone is a straight agonist. So that means it always turns on the receptors in our brains. Buprenorphine is a mixed agonist-antagonist. So that means sometimes it turns them on, sometimes it turns them off, sometimes it just blocks them. And so it can throw somebody who is dependent on opioids into withdrawal, which we don't want. And as with all things that are better, buprenorphine is much easier to access for people with private health insurance and money and cars and homes. And so you'll end up seeing a lot of those disparities with who gets buprenorphine and who gets methadone. Now for treatments. Parents are easily and by far the best treatment for any baby with any health condition, and especially babies with opioid exposure. The interests of the parent and the baby are not adversarial. A lot of times the folks that I work with will say, I don't care about the mom, I just care about the baby. You can't do that though. Up until a few hours ago, they were inhabiting one body. Their interests cannot be separated. If babies could talk, they would tell us that they want backup in there first. But the next best thing is to be with their parents.
One of the things that I tell all my families is that the #1 best treatment I have to offer their baby is them. And that's true not just for people with perinatal substance use, but particularly for people with perinatal substance use. Kangaroo care, or skin to skin, is just what it sounds like. It's holding your baby naked on your naked chest. That's a picture of me doing skin to skin with my niece Ellie. And kangaroo care has been proven to decrease maternal bleeding, improve attachment, decrease pain, decrease stress, increase initiation of chest feeding, increase breast milk supply, improve infant blood sugar, improve infant respiratory status, and improve infant temperatures. It is literally life-saving. It was invented, if you could say something that we've been doing for generations was invented at all, in Colombia in a newborn intensive care unit that didn't have enough isolates or incubators for all of the babies. And a doctor there got creative and said, well, I need to keep these babies warm somehow. What am I going to do? And so that doctor used the chests of the people who gave birth to those babies in order to keep them warm, and found that it not only kept them warm, but offered benefits for outcomes in multiple ways. It's really magical. We're still discovering all of the different ways that it can help babies. We know now, too, that if an infant becomes too hot, the maternal chest will decrease the temperature to match what the baby needs. It's really, really amazing and life-saving. And when I say it's literally life-saving, I'm not exaggerating. There was one baby that I took care of last year, and she was born at 24 weeks, which a normal pregnancy is 40. She had multiple surgeries. She had a tube down her throat into her lungs, helping her breathe for months. And there were 2 separate occasions where we, the nurses and the doctors, thought she's not going to make it. We called the family in. We told those parents, this is it. It's time to say goodbye to your baby. We took her off life support and we put her on her mama's chest, and both times she didn't die. Once she was placed skin to skin with her mother, she lived. It is that life-changing. And if you look at the list of things that we know that skin to skin provides for our babies, all of those things are extremely relevant for babies with prenatal substance exposure. They tend to have respiratory distress. Well, this fixes that. They tend to have increased use of calories and blood sugar. Well, this fixes that. They tend to have difficulty with temperature regulation and with feeding. Well, this fixes that. It's also the comfort aspect, because all of these things are caused by a pretty general pain response. And if we can get babies to relax and be calm, then we're halfway towards treating their condition. We have a lot of other treatments besides skin-to-skin care, both pharmacological and non-pharmacological. One of the best ones that research supports is breast or chest feeding. And we're not really sure whether this works to decrease the signs of neonatal opioid withdrawal because of the benefits of skin to skin and bonding and attachment, or whether it's because of the benefits of the tiny amount of opioids that gets into human milk. So we know from studies about methadone that roughly 2%, 1 to 2% of the maternal dose gets into the human milk. And so it's possible that that might help a little bit with the signs of opioid withdrawal, but usually it doesn't, it's not enough. I would suspect that most of the benefits that we see are from that skin to skin and bonding. If the birth parent's human milk is unavailable due to perhaps separation because of incarceration or bad systems, or perhaps the birth parent is continuing to use illicit substances, or perhaps they're using things other than opioids, I strongly, strongly recommend an exclusive human milk diet using donor milk, because we know for a fact that human milk is much easier to digest, it's easier on the stomach, it makes better poops than formula, and but we don't do it. I've invited every hospital I work at to consider doing this, but donor milk is expensive, and every hospital has very stringent rules about who qualifies for donor milk and who doesn't. And usually babies with opioid exposure do not qualify. However, based on the profile of their condition and their needs, that to me is balderdash. It's silly. They should qualify for this because it will directly treat so many of their gastrointestinal signs, as well as skin breakdown around their little bottoms from having that diarrhea all the time. So donor milk should be offered to all of these babies. Another thing that we can do is decrease stimulation. So this is one of the things that we do for these babies that we do it all wrong. What we should do, rather than putting them in a loud, noisy NICU away from their parents, is put them in a dark, quiet, private room with their parents where we can minimize stimulation, minimize interruptions in their sleep, and minimize a change in caregivers. So for a lot of babies, especially in the hospital right after birth, you've got grandparents and aunties and uncles and cousins, and everybody wants to come in and get a piece of that baby. So the baby's being passed around from person to person, and it's noisy and it's bright and it's a celebratory environment. And for most babies, they can handle that. But for these babies, that is the opposite of what they need. So what we want is dark and quiet and minimizing the number of people in the room. We want to also prioritize sleep. So for most babies in NICUs and in hospital environments, perhaps you just finished feeding the baby, just got that baby to go to sleep, and then the pediatrician comes in and they want to do their assessment. So then that baby's getting unwrapped and woken up, and it might take a half an hour even for a baby with no opioid exposure to get back to sleep. And so that is, again, the opposite of what we want for these kids. So ideally, what we would want to do is what we call cluster care. So that means if they have a few procedures that need to get done that day, say they need to get weighed and they need a blood test for jaundice and they need the pediatrician to see them, we would try to do all of those things at once so that baby only gets disturbed one time, and then the rest of the day they can have that uninterrupted sleep. Medications, when indicated, are usually morphine and methadone. Morphine or methadone, I should say, and I've worked at hospitals that use either or. I don't really have a strong opinion about efficacy of one over the other. If I did, I would lean more towards morphine. Morphine just has a little bit better of a safety profile. It clears the system much quicker, so that means if there's an adverse reaction or an overdose situation, then that's going to be over with much faster. Methadone's just a little bit more toxic in our systems and harder to get rid of because of its longer acting capabilities. We also have what we call adjunct medications, which are phenobarbital and clonidine. With adjunct medications, the idea is if your dose of morphine or methadone is getting higher and higher and higher, and you want to use something that can decrease the opioid requirement, then you would use one of these drugs. Phenobarbital is an anti-seizure medication, and it does come with its own profile of withdrawal signs, so we want to be really careful about using that. Clonidine is a blood pressure med for adults, and we're not totally sure why it seems to work for reducing the morphine or methadone requirement for these babies, but it does. The last thing, and possibly one of the most important, is a snug, tight swaddle. So every newborn baby wants to be swaddled tightly, which swaddle means wrapping them up in a blanket. And the idea behind that is, like I said in my presentation, babies want to be back inside the uterus. And so for the last couple months of pregnancy, the uterus is a really tight environment. So if they have that startle, that Moro reflex where they throw out their arms, they're going to hit their parent. And they're going to say, oh, there's my mommy, there's my parent, I'm safe. And so we want to do a tight swaddle for all of our babies, particularly, though, babies with opioid exposure. Now, if they have a high temperature related to that increased metabolic rate, or they're really fussing and crying and that's making them hot and sweaty, then we don't want them to overheat. So you can leave their feet open and just wrap their top half. And what I tell my parents is you just hold your baby like a little Dracula. You just cross their arms on their chest and wrap them up real tight, tucking the ends of the blanket underneath the baby so that their body weight holds it in place, and that can really help to diminish their signs of withdrawal and calm them down. For long-term outcomes for infants exposed to opioids in utero, the short answer is they're really similar to the community average for other babies that are born in that same neighborhood, in that same environment. There may be subtle differences, and I say that because research tends to find what research looks for, and there are a few problems with the way research is done on these populations. One of those issues is sampling bias. So we tend to do research on people that get caught. There are a lot of people who use drugs and a lot of people who use drugs while they're pregnant, but the only ones that we know about are the ones that we catch. And those people tend to already have involvement with child services or the criminal justice system. They tend to be poor, they tend to be brown, they tend to have a lot of other negative social determinants of health. And so what we find, I suspect, has a lot more to do with people's social determinants of health than with the actual substances. What research does find is associations. There is no proven causal relationship between any severe long-term effect with any drug, not just opioids, but methamphetamine, other prescription drugs, cannabis. It just is not there in the research. And part of the issue with that is the sampling bias, like I said, but also confounding factors. When we look at kids that are exposed to poverty, experience of racism, experience of violence in childhood, those kids have problems growing up. And most of the populations that we study that have prenatal exposure to substances also have a lot of those ACEs, or adverse childhood experiences. They also tend to have a lower socioeconomic status, and they also tend to have parents who are less healthy because of those same social determinants of health. They tend to have parents who use tobacco, which we know is, other than alcohol, by far the most harmful substance that babies can be exposed to prenatally. So it's really difficult to tease apart the research, but the fact that we've been studying this for, 50 plus years, and we haven't come up with anything other than these loose associations leads me to believe that our response is by far more punitive than our punitive response is by far more harmful to these babies than any prenatal substance use by their parents. We know for a fact that taking babies away from their parents is one of the most harmful things you can ever do for the development of a child. And so when we're looking at these families, we need to take that into account and not just assume that putting them into foster care, which we also know is a really traumatic system for people. Putting people in foster care is not fixing this problem. Thank you so much for watching. Here are my references, and as always, if you have any questions or you want to fight me about something, I am super up for that. Please give me an email or give me a call and let me know what I can do to help you learn more, or what you can do to help me learn more. Thanks.